Hi, we're here today with Associate Professor Bishal Gyawali, who's a medical oncologist at Queen's University in Kingston, Canada, and also co-founder and co-lead of the Common Sense Oncology movement. So obviously the first question is, can you explain to us what Common Sense Oncology is?
Yeah, thank you. It's a pleasure to be here. Common Sense Oncology is a movement involving oncologists like ourselves and physicians from other specialties, such as surgical oncology, radiation oncology, palliative care, and so on, plus the nursing staff, other healthcare professionals, and most importantly, patients, patient advocates, and other stakeholders, such as journal editors, for instance. So this is a coalition of people who came together for a common goal that we need to improve outcomes for our patients with cancer. Now, that sounds like a simple goal, and people can ask, oh, that's obvious. And that's why we call it common sense. Yes, it is obvious. That's why we call it common sense. But the problem is, we realize that in the last few decades, we have had several new innovations in cancer treatment that did not necessarily improve outcomes for patients. We had some phenomenal breakthroughs. I'm not discounting that. We have made substantial progress. It's far better to be, to be diagnosed today than to be diagnosed 20 years ago, because we have had several new drugs that have improved outcomes. But there is a majority of drugs that actually do not improve outcomes, or we do not have any idea by how much they improve outcomes, because they have not been tested to test whether these drugs actually improve outcomes for the patients that matter to the patients. So they have been approved on the basis of surrogate endpoints, for example. So we are not sure whether it translates to improving survival and quality of life. And there are other issues, such as the trials are not designed well to begin with. So even after the trials are completed, because the trial design was not ideal, we do not know how to use the drug in the real practice. So in our day-to-day life, when communicating with the patient, patients have so many questions about the drug. They say, what if I take something else? What if, how long am I going to live as a result?
Yeah.
Are those extra lives, days in ICU? Or are those good days where I can go and play, baseball with my son?
Yeah.
That matters. And the problem is we don't have answers, because the trials have not been designed to answer those questions. So this was a movement of all these like-minded people, so to speak, whose fundamental philosophy is we need to have answers to these questions. So we need to get together to maybe try to, create a positive change to the system. And by that, to be precise, we are working fundamentally right now on three, let's say, pillars.
Yep.
So those pillars are evidence generation, evidence interpretation, and evidence communication. And evidence generation is how we generate the evidence. So it is influencing trial design. How can we design trials well so that we get the answers to the questions we need? And then comes evidence interpretation, because, as I showed some examples in my talk yesterday, sometimes the trials are presented and published in a very, deceiving way, misleading way. The results are different, but the way they are presented are different. So we need those critical appraisal skills to correctly understand what the trial, what the inferences should be from the trial. Sometimes the headlines are not accurate. What we read in the abstract or the conclusion is not accurate. So how do we identify those issues that can subtly, bias the results? But if you are not paying attention, you miss them. So how do we, and our CSO RCT checklist that I presented yesterday was a culmination of the effort to improve evidence generation and evidence interpretation. So to develop those critical appraisal skills, especially for the trainees and the newer generation, to include that in the curriculum. And finally is evidence communication, which was the theme of my keynote talk this year. So how do we communicate that well? And communication has so many different angles to that. We talked about how the media can communicate the research findings properly to the public, how we researchers can communicate the research findings correctly in the publication, and how we physicians can communicate the findings correctly to the patients.
May I take that one step further? You talk often about how we are so invested in having to have a positive outcome, a positive statistically significant trial. Whether it's clinically significant perhaps is secondary when it comes to being invested in what that outcome is and the pressures. How do we, or are there any barriers you can think of that we can address or that you're addressing in terms of actually celebrating the scientific process and the analysis and the outcome rather than necessarily just having a positive outcome?
That's a very important point. So, in fact, one of our items in the CSO checklist is that trials should be designed and powered not just for a statistically significant outcome, but for a clinically meaningful outcome. For instance, we have ESMO magnitude of clinical benefit scale. So it can give us some idea about, the magnitude of benefit of the cancer drug, whether it's substantial clinical benefit or very marginal benefit. So we want to make sure that when clinical trials are designed, they are already designed to test for that substantial magnitude of benefit, because we have seen instances where there is improvement in survival of 3 weeks, 2 weeks. Is that even meaningful? At what cost? Both physical toxicities, financial toxicities, and even time toxicity. If those extra 3 weeks or even more are spent in ICU, then that's actually a net loss of longevity, right? So we would need to make sure that we are not just changing this arbitrary p-value of 0.05, which has absolutely no practical significance, but we are chasing a metric that is meaningful for the patient.
Yeah, I think that's really important, not just to concentrate on the p-value. I want to touch on something from your talks yesterday, and we've had a bit of a chat about this. So I always think that when people are sort of talking up the trial results, it's often, oh, surely that's the pharmaceutical companies trying to sell their drugs or whatever. But I wonder sometimes if you're an investigator yourself and you've spent the last few years, really believing in a project, that you could be guilty of it too. So I was just trying to get an idea of, are there those that are more guilty of not having common sense oncology in this space, if that makes sense?
Yeah, no, that is an exceptional question that I have not been asked before. But we are absolutely correct. I think if you have, just to give you an example, if you have spent last 3 decades of your life researching, and I don't know, let's make it up, EGFR receptor, then your whole life is focused on EGFR receptor. So all you'll think about is how to target it, what happens if there is resistance, how to target that resistance, this molecule, that molecule. But you miss the broader picture, the bird's eye view, the overall picture about, is it ultimately improving quality of life of the patient? Is it ultimately improving survival? If you compare, what happens if you compare that against other tumor types? For example, what's happening in ovarian cancer, what's happening in breast cancer? So I think we need that broader eye view with a policy lens, because if you are invested in a small, minute, niche area, then of course, the whole world will revolve around that for you. And that's why we are guilty, as you mentioned, we are guilty of overselling our own results. It's not always the industry. Of course, industry has a financial interest. And of course, when $1 billion are at stake, honesty comes, it takes a backseat. Who cares whether you're honest or not? You have billions of dollars at stake.
Yeah.
But even as PIs and researchers, I think we are also guilty, because it's not $1 billion at stake for us. We might have our financial conflict of interest, which is a big deal again. But even beyond that, I find that, especially when it comes to media overselling the results, because the media people, I'm not blaming them, because they don't have the same level of expertise and training as we do. So they are relying on us. And when the PI is overselling his or her own result to the media, then the media believes them, right? So if you have discovered something new, then, as a PI, you are, I think it's human nature that you get super excited and you want to oversell the findings and say that this is going to be the game changer, this is going to be blockbuster. And that's why we get headlines saying we have this fantastic new drug for this cancer. And then you read the fine prints and it's in mice, right? It's not even in humans. So what percentage of those drugs that work in mice ultimately end up being even tested in humans and ultimately being approved and improving outcomes in humans? It's a very, very small percent.
Yeah.
But for someone whose whole career is surrounded around that small topic, I think the bottom line is, what I'm trying to say is, we also share the blame. So we need to improve ourselves.
We can all be guilty of it, I guess.
We can. And as part of that, actually, you I know, again, you've mentioned before, but we often focus on statistical significance and bias. But there are many other considerations when it comes to actually what is meaningful from a trial and considering and what we should take into account when designing trials, research outcomes. What are some of those? And should we be focusing more on that than just the biases even?
No, so I think we need to focus on both trial design and trial reporting, because sometimes, the trial is already done. So you can't go back and redo the trial, right? So you already have the results. So you have to deal with whatever you are presented with. For that, critical appraisal skills are important. But if you are starting a trial, then you can design it properly. That's why we have two checklists, one for design and one for reporting. So for instance, in terms of designing the trial, one of the commonest issues that I see is control arm. Like, we are using really bad control treatment that we would not have offered in our routine practice. So one of the fundamental principles of clinical trial is no patient should be harmed as a result of participating in these trials, correct? If you are doing, I don't know, let me be provocative, as if I'm not. Let's say we have a new prostate cancer trial, and we are using the control arm of ARPI after ARPI, right?
Will be placebo.
Worse than placebo. I think it's worse than placebo. Yeah, AB after ENZA, ENZA after AB. We are still using that control arm, correct? If our patient was not a part of the trial, in our routine practice, would we do that? No. But because that patient is a part of the trial and unfortunately got randomized to the control arm, now that patient is being harmed. So the first most important thing is, what is our control arm? Is this what we would have offered to our own parents if they were not a part of the trial? And if the answer is no, then we are not ethical in offering that to other patients. A. B, just throwing out some examples. One is control arm issue. The other is crossover, right? So let's say we have, again, this is a GU space. Let's talk GU trials.
Yeah.
Let's say we're doing a trial of adjuvant immunotherapy versus placebo for renal cell cancer. Okay.
Yeah.
Now, those placebo patients, when they eventually relapse and progress, should they or should they not receive immunotherapy? They should.
Yes.
Because the question is not whether these patients should ever receive immunotherapy. We know that they benefit. They should ever receive immunotherapy. The question is whether they should receive immunotherapy now,
Yeah.
or in the future.
Yep.
Yeah.
Right? And if you don't give these placebo patients immunotherapy in the future, A, you're depriving them from standard of care because they reach standard of care at first-line relapse. Then B, you are not even answering the scientific question, that is, should I give it now or should I give it in the future? So what purpose did it serve?
So it's about asking the whole question, not just an immediate question which you can try and get a positive answer from.
Exactly. So the issue of crossover, right?
Yeah.
So in these trials, there should be mandatory crossover.
Yes. No, you're preaching to the converted. I'm just going to have to remember this when we set up our next lot of ANZUP clinical trials, because now we recall it. Won't keep you much longer, but I just wanted to touch on your health equity session. You talked about the things that do impact both worldwide, and I don't know if you've got any examples for Australia, but I thought that was a really interesting comment, and I just wondered if you could just comment on those.
So I talked about cancer ground surge, and I did give examples of what's happening in low-income countries versus high-income countries. But you're absolutely right. Like, even within a high-income country like Australia, I know that for Canada for sure, but I'm pretty confident it's the same for Australia, that you'll have pockets of population whose outcomes are even worse than patients from low and middle income countries,
Yes.
right? So there is global oncology in our own backyard. There is pockets of population whose outcomes are so bad, and it's within a high income country. So, when I talk about this cancer ground surge and global oncology, usually our audience from high income countries, they think that, oh, this is about Africa, this is about Nepal, this is about other countries. No, this is about your home too, because there is so much disparity within the same country. So how do we address that? If patients in Australia, some parts of Australia, they are not getting access to timely surgery for their colon cancer, for their kidney cancer, whatever, then what sense does it make to celebrate about the fanciest new molecule,
Yeah.
which is not going to reach them in next 10, 20 years. So how the fundamental principle of ground surge that I wanted to promote was that of prioritization. How do we prioritize things? So for these patients who are not even having access to surgery, or who are not even having access to proper palliative care, I think the first priority should be to ensure that, yes, they do get surgery in time. They are accurately diagnosed. They have access to CT scans. Their pathology is accurate. So how do we ensure that? Like, taking baby steps before trying to run, right?
Yeah. And I think I think we can automatically think of some groups and sort of the regional versus city as where the disparity is. And there's obviously certain populations who are underrepresented and under-resourced. Indigenous people, obviously, we need to do better for. I will say that ANZUP has certainly got a new strategy, and we're trying to include diversity in that. So perhaps we're doing some common sense ANZUP in there. So it's really important to think about walk before you can run. I think that's great.
Yeah. I just have one maybe curveball question to throw at you for a wrap up, which is the role of the media in all of this and the perception. So we know that common sense is not so common, and the media can sometimes be our Achilles heel and can sometimes misreport.
Yes.
Can we turn that around? What can we do to actually make that media, make the public perception actually our friend in this scenario?
Yes. No, that's that's a very important question. So at Common Sense Oncology, we are trying to, involve more and more media. So, one of our problems is we have limited bandwidth. Like we are a group of full-time practitioners.
Yeah.
Like I have my own full-time job and I'm doing Common Sense Oncology on top of that. And that is true for other members of CSO. So we are quite limited. So we have not been able to, do a lot of things at the same time, but it is in our future radar to work with, journalists and maybe launch like a workshop for the media people, which could even be virtual so that anybody can join from all over the world, to give them a proper training on these nuances of how to report accurately, because we can't just be blaming them when we are not reporting our own results accurately, right? A. And B, the other thing is, I think there is also some role of social media here, and that's the reason why I try to stay still active on social media, because now, especially the benefit of social media, I find is I can directly reach to the public without having to go through the third party of traditional media. So I can go to the public directly, I can share my results, I can talk to the public directly, and I think that has made a big difference. And the third point is especially not just media, but also about the trainees, right? Because one of the reasons among many reasons, one of the reasons that we started Common Sense Oncology was also because the trainees kept telling us that they would go to these big meetings and they would look at like the role models, like what is the definition of success in oncology, right? If you are a trainee, if you are just starting your oncology residency and you want to be successful in oncology, who do you look up to? And you want to be like one of the KOLs. And what are the KOLs doing? The KOLs are doing these bad trials, right? And so they did not have good role models in oncology. So one of our motivations was, if we form this group, then they can look up to people and say that, okay, there is an alternative career path. You don't always have to do this. You could go to the podium even without, even by being honest. So that was also one of the motivations. So if we can inspire enough percentage, if we can reach that threshold number of the new generation of oncologists, of the new trainees, then I think they can also make a big impact.
Well, on that way, I mean, it's so refreshing to listen to you, and you're always so honest, and it really is what we need in oncology. In fact, it's what we need in medicine, full stop. And of course we do. How do we actually join? What advice, where can we go? How do you get involved?
Thank you. So to get involved in Common Sense Oncology, people can go to our website, www.commonsenseoncology.org. And there is a button to say become a member. It's for free. So anybody can become a member for free. If you want to donate, you also have an option to donate. You don't have to. You can become a member for free. By doing that, you'll get our regular newsletters and you can stay up to date about what we are doing. For example, we frequently do satellite events at ASCO and ESMO. So people can come and meet Common Sense Oncology leaders there, listen to our presentations and get more in touch. And we also do virtual, like we did something similar to Best of ASCO, like the highlights of ASCO. We did that virtually, so anybody could have joined. We also have a presence on LinkedIn and X. On X, it's @CS Oncol, ONCOL. So yeah, at the moment, these are the ways in which people can join the movement and be a part of the movement and stay up to date. To get involved even more, that has been one of our good problems to have, because when we started, we thought maybe it will just fizzle out, like we don't know what type of reception we'll get, but the reception has been so wonderful. We already have more than 3,000 people from all over the world. And these are like motivated, passionate people. They have joined for a cause. So they are all telling us like, how can I contribute? I joined, but I have not done anything. I want to do something. And our problem has been that we don't have enough things to let every people do something about it, which is an excellent problem to have. But just being aware of this movement and trying and understanding what we are trying to achieve. And as you mentioned, like now, in your next meeting, you are going to bring these things up. So doing your part wherever you are, that is meaningful. But we'll also slowly start to think about other ways for people to get involved. And one of those is we are thinking about the concept of regional hubs, like, CS or Australia hub, for example, right? And that regional hub can take care of the members within the region and get them more involved. So that is brewing. So stay tuned.
So does it. Well, you may have an skip in or uptick in membership after ANZUP, because everyone's been very delighted to meet you.
Thank you.
And
It has been my absolute pleasure, to be honest. Like, usually, as you can guess, clinical trial group and my philosophy can sometimes not go parallel.
Yes.
Because clinical trials are heavily influenced for profit. But there are excellent group of other clinical trial groups, doing independent research, or even like pharma-sponsored research is not necessarily bad research,
Yes,
right? And we need people working with the industry who push for these things. Otherwise, it won't change. Like, you can't just be criticizing and hoping for change. We need people who are also working with industry who can drive the changes.
Yeah.
So, of all the meetings that I have gone, I have felt very much happy and home at ANZUP. And I'm not saying this because I'm here, because I have great colleagues like you, and people that I respect, like Chris Sweeney and Ian Davies and Martin Stockler. These are people that I look up to.
yeah.
And these are the people who I believe can effect the change that we have been advocating for.
Yeah.
So it's an absolute pleasure. Thank you.
Well, we'd like to thank you very much for being part of ANZUP in Conversation, for being part of the ANZUP meeting. And you're welcome back in Australia and ANZUP at any time.
Anytime. Thank you.